Hello, friends. Yesterday I was a bit busy, so I could not take the class. So I'm taking it today. There have been a lot of requests from first year and second year PGs to take some basic classes. This may not be very useful to the, or may not be very interesting to the clinicians, but I'm sure the first year, second years, and even the exam going PGs might find it very, very important. This is the important topic according to me in obstetrics because cephalopelvic disproportion is an important aspect which has to be ruled out before we allow a patient for vaginal delivery. There is no doubt about its assessment. Maybe there is controversy with regards to when it has to be assessed, but everyone must know how to rule out CPD. Otherwise, you will land up in obstructed labor, and that will land up in rupture uterus, and that will be the end of our career. Of course, the end of the patient as well. So today I thought this is an important topic, and let me deal with this. And whenever we talk about CPD, trial of labor, we must talk about pelvis and skull. So I will start with the pelvic assessment and some important diameters and other aspects of the mechanism of labor. The ideal obstetric pelvis, of course, all of us know out of the four is gynecoid pelvis. Others being platypelloid pelvis, which is okay for vaginal delivery, whereas android and anthropoid pelvis definitely are not okay for vaginal delivery. So the whole aim of pelvic assessment is to rule out an android pelvis. We are not so much worried or we are not so much particular about platypelloid and anthropoid pelvis. Basically, we want to rule out that it is not an android pelvis. So when we assess the pelvis, we can talk all points in favor of gynecoid pelvis. It is always better to talk in one particular theme rather than jumping from gynecoid to android, android to gynecoid, and things like that. Automatically, when you say this is in favor of gynecoid, the other is android pelvis. So there are different levels at which we can assess the pelvis. The pelvic assessment is clinical rather than by other methods. The radiological assessment of pelvis is totally given up. That is X-ray pelvimetry, thankfully. We had to otherwise remember when I was a UG and a PG, there were four types of different views that we had to learn. Ultrasound assessment of pelvis and MRI assessment of pelvis also are not done routinely. They are done only in the research setup. So essentially, it is clinical. We would like to go in a systematic way. That way we can remember easily. I do not want any postgraduate to by heart this. So you just imagine that you are in the labor room and you are doing the pelvic assessment, and it has to be done in a systematic way. Otherwise, you will be doing multiple pervaginal examinations. So once you start the pervaginal examination, you will always start from above and then you go systematically downwards and you come out. You will not go in and out of the pelvis, isn't it? So the first thing that has to be assessed is the brim. You will soon realize why it is important, because the assessment of cephalopelvic disproportion is essentially at the brim. So the brim has to be perfect. It's like gateway. If the gate itself is narrow, you can't even enter. Forget about going through the other small avenues in the particular compound, isn't it? So brim is very important. And how do you assess the brim? So you will just put your two fingers and try to reach the sacral promontory. There are different diameters that are given in the textbooks. It is impossible humanly to remember all the diameters, and I do not want you to remember the diameters actually. Roughly, if you remember, all the diameters should be more than 10 centimeters. That is more than enough. practically speaking. If you have no other job, you well and good, you remember all the other diameters. So it has to be minimum 10, isn't it? So there is a bony diameter and there is in a live patient where the soft tissues are there. So when you do this diagonal conjugate, you have to deduct 1.5 centimeters to get an obstetric conjugate. So all those calculations, all those numbers, we can keep it aside, because in labor room, we are only interested whether a given baby can come out of this pelvis and whether this pelvis is gynecoid and nice. I always teach that you have to remember the subject, if possible, in a given topic by one word. You may wonder, how can we remember everything in one word? The one word that you have to remember as far as the pelvic assessment and pelvis is concerned is round. So the gynecoid pelvis is almost round. Only when if it is round can there be rotation of the baby, which is very important in the second stage of labor. And the baby can smoothly go inside. If it is semicircle like this, as in case of android pelvis, that is behind it is flat and there is a small semicircle, or even sometimes the android pelvis is not even semicircle. Semicircle is only at the in the mid cavity, whereas at the entrance it is almost like a heart shape. I always joke saying that men have got heart in the wrong place, that is in the pelvis. So there is beaking in the front and the brachial promontory is jetting inside. So this is not a good pelvis for the baby to enter and just rotate and all those things. So one word to be remembered in gynecoid pelvis is every level, brim, mid cavity, and even at the outlet, at least there has to be a nice and round circle wherein this BPD and other engaging diameters will rotate easily and the baby can come out smoothly. So coming back to the brim, we are not actually measuring anything. By qualitatively we can say whether the brim is adequate or not. So when you do a PV, if you can easily touch the promontory, that means it is beaking inside, isn't it? So if it is round, you cannot touch the sacral promontory. So the first point is that sacral promontory cannot be reached. That's the first thing. I hope it's very clear. If you can touch means the sacrum is jetting into the inlet. So that is not good. The second point, as you are there, after that, see, I'm imagining the pelvis. You also should imagine the pelvis like that in the mind. You should always transform yourself into the clinical, scenario. So from there, I just go all around, and that is called iliopectineal line. That has to be round. And I come to the front. There should be no beaking. For example, like this. If it is like this, this is beaking in the front. That is in the android pelvis. So it should be round. When it is round, there is no beaking at all. So these are the two important points at the level of brim. And that is more than enough actually, because it is believed if there is no contraction at the brim, very, very rarely will there be contraction at the mid cavity and the outlet. So that's why these 2 points are very important. In that, if you ask me one point, that sacral promontory, you should never be able to touch. So that is a good inlet. Then we have to go to the cavity. There are several points. Again, I will not jump. I just finished sacral promontory. I just went around and came back to sacral promontory. The next thing I have to do is I have to just sweep across the sacrum. So when I sweep across the sacrum has to be well curved above downwards as well as sideways. If it is flat, that's the time you get that semicircle. So sacrum is flat and then you get the rest of it round. So semicircle, if it is semicircle, there can't be rotation at the mid cavity. All of you know that the rotation mainly occurs at the ischial spine level. Ischial spine level has got so many important aspects. That's the level where we can also think of the engagement of the head, isn't it? the head has to, or the whichever is the presenting part, it has to reach the sacral spine. And that's a place where the rotation also takes place, or the head gets stuck in a deep transverse arrest. So sacrum should be well curved above, downwards, and sideways. Now you see, I finished with the sacral promontory, went around the inlet and came back, and now I've gone to the sacrum well curved above, downwards, and sideways. Now when I go to the sideways, there I get the sacrosciatic notch. Okay, the sacrosciatic notch must admit 2 fingers. If it is very narrow, if it doesn't admit, that means the mid cavity is sort of contracted. So sacrosciatic notch should admit 2 fingers. Now you see how beautifully and chronologically step by step it goes. The next point is obviously the ischial spine. This is the ischial spine. So I just came from sacrum sideways, sacrosciatic notch admits 2 fingers. Then I get this ischial spine. This should be everted outside. If it is jetting inside, both the spines are jetting inside. If they are prominent, that means the mid cavity is narrow. Everywhere I told you, remember 10. Dr. Pratap's favorite number. He always says in obstetrics, you can remember everything as almost 10. So 10 centimeter should be the mid cavity in between. So obviously the next point is both ischial spines cannot be touched simultaneously. You are at one ischial spine. Now you just try to spread your fingers, and you should not be able to touch both. So if you want to touch the other side, you have to leave this and go and touch. Come back, leave, and come back. So that means there is minimum 10 centimeters. So I'll repeat everything in a stepwise fashion. First one is the sacral promontory should not be able to reach. The the iliopectineal line should be round. There should not be any peaking. Come back. Sacrum is well curved above, downwards, as well as sideways. Here I get sacrosciatic notch, admits 2 fingers. Then I get the ischial spine, which is everted, and I'm trying to now touch both the spines together. Now they are not able to do that. And when I come down, I should not be converging my fingers. If I converge my fingers, means the pelvic cavity is converging. The pelvic side walls should be parallel. Only when the side walls are parallel will there be a good circle at the mid cavity. And that is the one which is helping us for the rotation of the baby. The side walls should be parallel. So there are many points in the mid cavity, but it's not at all difficult. Sacrum is well curved above, downwards, and sideways. Sacrosciatic notch admits 2 fingers, and ischial spine is everted. I can't touch both the ischial spines together, and as I come down, side walls are parallel. So these are the points in cavity. Now we'll go to the outlet. Now outlet, as I came down, I hit the coccyx. Coccyx is a part of the outlet. So 2 ischial tuberosities and the subpubic angle, and behind is the coccyx. Coccyx also should be everted. Only if it is everted, if it is possible to have a nice round there, as well as in between that almost diamond shaped outlet. So in between, I should be able to get a round there. So if the coccyx is jetting, then it will not allow the baby to come out. Then subpubic angle. If it is narrow, again, I can't get a circle there. It should be wide and nice, obtuse angle. Okay. And all these things went in a fashion and coming out. And finally, I can get my hands out. And now I'll make a knuckle. And this knuckle is to be put between the 2 ischial tuberosities. They must admit 4 knuckles. That is a good outlet. Baby can come out easily. So let me repeat for the last time, above, downwards, in that order. Sacral promontory cannot be reached. Iliopectineal line is round and there's no beaking in the front. Outlet is assessed, inlet is assessed, and it is nice. Come back. The sacrum is well curved above, downwards, as well as sideways. When I come to the side, sacrosciatic notch admits 2 fingers. Ischial spine is not everted, and then, it is everted, and then when I want to touch both the ischial spines, I cannot do that. That means minimum 10 centimeters are there. And then when I come down, the side walls are parallel. I finished with the mid cavity, everything is fine. Now I try to go for the outlet. As I come down, I hit the coccyx, it is everted, and then I just rotate my fingers from like this to like this. The subpubic angle admits 2 fingers, and now I totally come out. The ischial tuberosities in between them, they admit 4 knuckles. So this is a perfect gynecoid pelvis, round and nice at all levels, minimum 10 centimeters. I think you can remember this for your life. Now I come to the fetal skull. You know, all of you know this. There are different bones. I don't want to get into that. And there are, of course, the sagittal suture, and then there are coronal sutures, and in between you have this fontanelle, and then there is bitemporals and biparietal diameters that are important. Again, these are the diameters. I have a very simple and easy way of remembering all of these diameters. You have to go in one order only. Then you will not miss anything. So here is the skull I put in a diagrammatic way. This is the biparietal, eminence and the diameter part. Here is the vertex, green dot, and here is the face, yellow dot. And that is the brow, and that is a glabella, that's bregma, and here is the occiput, and then that's the chin. Now, I told you start in one direction. I start from subocciput, okay, from here, and I end with bregma. So this is number one. This is also number one. Why I have written this 4, you will realize later. So from 1 to 1, if I draw a line, this is called suboccipito-bregmatic. And what is there in between is vertex. So in vertex presentation, the engaging diameter is suboccipito-bregmatic. Now, many students get confused. What is engagement and what is engaging diameter? Engagement is very simple issue when biparietal diameter, which is the transverse diameter, the broadest diameter, 9.5 centimeter, it crosses the pelvic rim. That's all. But when the head enters, in the sagittal diameter at different levels, like this, if you consider, if you take a slice of the head, like if I take a slice here at the suboccipito-bregmatic, that is the engaging diameter for the vertex. Then I move once, that is 9.5 centimeters. That's why students get confused. Suboccipito-bregmatic is also 9.5 centimeters and BPD is also 9.5 centimeters. There's one more 9.5 centimeters. That's why I just now clarified. I have to move just one point, go slowly, point by point. So I move one point, what do I get? Occiput. Here I have to move further. So what do I get? Frontal bone. So the next diameter is occipitofrontal, which is 10.5 centimeters. What is there in between? It is vertex again. So vertex has got two engaging diameters. One is suboccipitobregmatic, which is 9.5 centimeters. Other one is occipitofrontal, which is 10.5 centimeters. What is the difference? Suboccipitobregmatic diameter, which is 9.5 centimeters, the head is fully flexed and it is easy. Whereas when it is occipitofrontal, head is just deflexed and that is not easy. Anything that has to deliver, it has to be less than 10 centimeters. Just remember this. Anything that has to deliver, it has to be less than 10 centimeters. Only then it can negotiate. So how does this baby deliver then? If it is vertex but 10.5, the baby has to flex nicely. So you have to bow down to the mother, then only you will deliver. So you have to flex nicely, even in life, in order to get delivered. Not all the time, of course. Sometimes you have to stand up against the atrocities. But most of the time, a flexed attitude is a good attitude. Now I move one point from occiput. What is the next point I get? I get here is vertex. So when I move from here, what do I get? The next point is the mentum. So I join these two lines, 3 and 3. I get mento-vertical. What is there in between? Brow. So brow is 13.5. Do you think it delivers? And even 10.5 is not delivering. How can 13.5 deliver? So brow, there is no mechanism of delivery at all. So now I move one more point from vertex, I reach bregma. There is a fourth point. That's why this was the first point as well as the fourth point. Now when I move from here, the fourth point, this side is submentum. So I join these two fours, that becomes submento-bregmatic diameter, and that is also 9.5. What is there in between is face. So face is also 9.5. So we have got two 9.5s now in the sagittal diameter. One is suboccipitobregmatic, other one is submentobregmatic. Okay, so I make it yellow. They are like equal and opposite in the sense the two sides of an equilateral triangle, 9.5. So whenever it ends with bregma, it is 9.5. And whenever there is word sub, it is 9.5. That is suboccipitobregmatic, submentobregmatic. What is the difference? The difference is in suboccipitobregmatic, it is vertex presentation, head is fully flexed. Whereas when it is submentobregmatic, it is face presentation, head is fully extended. Now, in between, you have a deflexed head, that is occipitofrontal, and de-extended, if I can use that word, or semi-extended head, that is bro presentation, mentovertical. I hope this is very clear. And the engagement with respect to the transverse diameter, that is BPD, biparietal diameter, that is also 9.5, but that is only to be used in order to say whether it is engaged or not engaged, not the engaging diameter. So now I come to the main topic. I had to spend so much of time to explain to you all these things. Then only it becomes so clear later, and I can run through the topics. What is the definition of cephalopelvic disproportion? So far, what we have understood is the pelvic assessment. Yes, let's say pelvic assessment, pelvis is gynecoid, which is conducive for vaginal delivery, as I told you, no doubt in that. And all the diameters are more than 10 centimeters. But it is not just the pelvis that determines the vaginal delivery. The baby also, passage and passenger. Of course, the third P is the power. I will not talk about that today. Now, the passenger is also very important. If the passenger is bigger, let's say you have made a nice, beautiful, door. The standard diameters of the door, let's say it is 7 feet high and then 4 feet wide and all that. But an elephant cannot enter that. Only you can enter that. So that's why even if the pelvis is nice and round and gynecoid, if the given baby is bigger than this pelvis, there can still be cephalopelvic disproportion. So at this juncture, I want to clarify to all the postgraduates is that don't get confused with contracted pelvis, CPD, and the gynecoid pelvis and things like that. Yes, gynecoid pelvis is a conducive pelvis for vaginal delivery, but that also can have CPD if the given baby is bigger. That's why CPD simply means cephalopelvic disproportion. Here we are not only taking pelvis, we are taking cephalus as well. What is a contracted pelvis? Let me tell you. Contracted pelvis is a smaller pelvis, contracted. And if you want to have a quantitative definition of that, contracted pelvis means it is smaller by 1 centimeter at all levels. What do you mean by all levels? At the brim, at the mid cavity, at the outlet. So it is 1 centimeter less than the expected diameters. There are so many expected diameters. Everywhere it is 1 centimeter less. Now you may ask me a question. Sir, will contracted pelvis always have CPD? See, whenever the question contains the words like always, never, and all this, these are very tricky words. So when you hear such words, the answer automatically is there in the question. Always, no. Whenever the word comes always, no. Okay, nothing is always. So just because it is contracted pelvis, if the given baby is smaller than that pelvis, it can still deliver vaginally. You got my point? So CPD can occur in a normal pelvis. There may not be any CPD in a small pelvis. It all depends upon the perfect fit between the baby and the pelvis. Is it clear? So now let's move on with the definitions. Disparity in the relationship between the head and the pelvis, 1 centimeter less at all levels. Okay, you need to know the qualitative definition, which simply says disparity. But you must know the quantitative definition, because that's the one which will later tell you whether this given patient can go for trial of labor or not. I will explain that beautifully little later. So right now you remember it's less by 1 centimeter at brim, at mid cavity, and at outlet. It is applicable only in cephalic presentation. This is very, very important for you to understand. We never talk about CPD in breech, because in breech, the presenting part is the base of the skull. Base of the skull is one thing. Secondly, the baby is in a sort of extended position. So you get a very, wider, what do you call, the diameter in the cephalus. So you can't be assessing that at the beginning of the labor. If you cannot assess anything at the beginning of the labor, you are in for trouble, isn't it? Suppose you think that the breech is softer always and it will come through, and you get stuck at the level of the head. I mean, you are stuck for life. I mean, you don't know where to hide your face, or whether to go inside the earth or whether to fly off into the sky. You are stuck with the baby's head inside. The rest of the body has come out. So you cannot assess. So anything that cannot be assessed right in the beginning of the labor, you will not consider that. That's why, whereas in cephalopelvic disproportion, you can assess that right in the beginning of the labor. And if the head can deliver, rest of the body can be definitely delivered, because it is softer and moldable. Head is the one which cannot be molded that much. There is a physiological molding though, that I'll come to little later. What do you call the disproportion in breech then? Some students ask me, sir, what do you call that breech? Can we call it fetopelvic disproportion? Yes, you can call it fetopelvic disproportion, but it is very difficult to assess. You usually indirectly assess by the weight of the baby. If the baby is huge, more than 3.5 centimeters, kgs, or even sometimes in the Western standards, it is 4 kgs, you should not take any risk by giving vaginal birth for such a breech or the malpresentations. So that's why you can call it, if you want, fetopelvic disproportion, but we are not going to assess that. We are only going to assess cephalopelvic disproportion. Let it be clear. What are the causes? Obviously, may either be due to a normal pelvis with a big baby. I have explained this. I don't want to waste time anymore. Or an average baby with a small pelvis. Both are possible. Normal pelvis, big baby. Average pelvis, small. Average baby with a small pelvis. So both are the causes. Gynecoid pelvis is no guarantee for vaginal delivery. I have explained this very, very nicely. Just because a lady has got gynecoid pelvis, it is not a guarantee for vaginal delivery. And my humble request to everybody, seniors and juniors and middle order and everybody, is that don't have a fixed idea that you must give vaginal delivery or you must do abdominal delivery. Both are wrong. If you have a fixed idea of I must give vaginal delivery for everybody or I must do abdominal delivery for everybody, that is cesarean section, both are wrong. You must try to give only a safe delivery. And that's where this topic is very, very important for you to understand. What are the FAQs in this? Are CPD and contracted pelvis same? I have explained that. Now you must be able to answer. No, CPD is possible in any pelvis, even in a normal pelvis. And contracted pelvis may not have CPD. Where is the disproportion? This is just, recapitulating what we have understood. Usually at the pelvic brim. Isolated mid-cavity and outlet contractions are rare, but it is possible. CPD diagnosis is with reference to brim. I'm telling it the third time. That's what Dr. Padma Rao said. Repetition is the essence of teaching. How do you diagnose CPD? Yes, it is clinical, and clinical. As I told you earlier, there's no X-ray pelvimetry in modern obstetrics, whether it is pelvic assessment or CPD assessment. Yes, ultrasound and MRI pelvimetry as well as CPD assessment is done in the research interest only, not routinely. There are many papers are now coming out in Manipal. There are doing a lot of theses on noting the different angles, different diameters with ultrasound in labor, early part of labor, and trying to predict whether it can go and all that. But none of them are now concrete. So that's why this CPD assessment done by pelvic assessment is still on. So the clinical diagnosis can be two types. One is abdominal, which confirms the possibility of entry of head into the brim only. It will not tell you about whether the head can be engaged. Indirectly, you can say if only 2/5 of the head is palpable, head is engaged indirectly by Crichton's maneuver. But you have to have the proof of the pudding by direct pelvic examination, isn't it? So that is why abdominopelvic or abdominovaginal, which is popularly called MunroKerr Muller method, is very, very important. You must remember this name at least. You may not remember the names of many procedures. That's okay. But abdominovaginal is by MunroKerr Muller method. It confirms not only the possibility of entry of the head into the brim, but also you get the proof that the lowermost part of the presenting part, in case of vertex presentation, it is vertex, or in case of face presentation, it is let's say face, is at the level of ischial spine. That is engagement. So, okay, in case of vertex, if it is at the ischial level spine, it is more than enough because of the mathematics which I'm going to teach you a little later. Whereas in face presentation, for the head to be engaged, the face has to be at least 2 more centimeters lower than the ischial spine. I will explain all these things why. But anyway, the abdominovaginal method will reconfirm that the head that has entered into the pelvis can go as low as a point where you can confidently say the head is engaged. In case of vertex, it is ischial spine. In case of face, it is +2 station. So what is this MunroKerr-Muller's method? The right hand, is the one which we always use for a bimanual examination. The fingertip is at the ischial spine and waiting for the head to come down to that level or the face to come lower than that to confirm the possibility of engagement, right? And the thumb is kept on the symphysis pubis to note the flushing of the head, whether the head goes just inside or whether the head goes up by lifting the thumb. It doesn't lift so much, but I'm making it dramatic to teach you. And then the left hand is trying to push the baby down, head down. Pushes the head downwards and backwards in order to make sure that we can get the baby as low as ischial spine. This is one. So this picture is straight from Williams. Many people argue whether CPD assessment is relevant in modern obstetrics or not. Even the 25th edition of Williams has got this picture. They talk about CPD assessment. There is no controversy with regards to assessment of CPD. The controversy is only the timing of assessment. Okay. So now engagement. I come to this part. I want to explain this one more time, though I explained a little bit in the past. So there is brim, yellow line, and ischial spine, that is green line, because if it comes up to that in vertex presentation, head can come through. Now you see here, this is face, this is vertex, and this is BPD. I'm using the same dots as I used earlier. Now it is clearly above the brim. According to the definition, when BPD crosses the pelvic brim, it is engaged. Now, what is the proof of the pudding? When BPD has crossed the pelvic brim, the vertex has come as low as ischial spine. Why is this? This is because of a simple math. I will teach you that mathematics. The mathematics is the vertical difference between the brim and the ischial spine is 5 centimeters. And incidentally, the vertical distance between red dot and green dot, that is BPD and vertex, is also 5 centimeters. So that is why when the BPD crosses the brim, obviously vertex is 5 centimeters below, and incidentally, ischial spine is also 5 centimeters below. So that is why when you put your fingers at the ischial spine and when you push the head and the lowermost part of the vertex presentation, that is vertex, when it touches the ischial spine, you can confidently say this head is engaged. Because in Crichton's maneuver, you can't really palpate the brim and with the BPD and all that, whether the BPD has gone below the brim and all that. You will only palpate 2/5 of the head, 1/5 of the head. And this is so rough. What is 1/5 for me may be 2/5 for you, and vice versa. Now let me explain to you, I was telling you, in face presentation, the mathematics is slightly different. Now it is ulta, right? Vertex is above, BPD is still above, and face has touched the ischial spine. Is the head engaged according to definition? Answer is no. Now here, when the vertex touched the ischial spine, head was engaged. Whereas when face touches the ischial spine, face is the presenting part in face presentation. It has touched the ischial spine. Yet, according to definition, it is not engaged because BPD is still high. Why is this? This is because of the simple mathematics. The distance between red dot and yellow dot now, that is the face and BPD, is 7 centimeters. So, if the face has to be engaged, where should you palpate the face? 2 centimeters below the ischial spine, in other words, +2 station. Now, the BPD has crossed the pelvic brim. So, in case of face presentation, if you want to confidently say that the face is engaged, face should be at +2, not ischial spine. I hope this picture is very clear. Take a screenshot of this picture. So now I come to the simple part and easy part, interpretation. So you will say no CPD when the head can be easily pushed without touching the thumb. So it easily goes inside. And not only that, the vertex is felt at ischial spine, which means head is engaged. No problem, no CPD. This baby can have vaginal delivery. I'm using the word can have vaginal delivery. Doesn't mean that it should have vaginal delivery, because, you know, vaginal delivery has got so many other things. There should not be fetal distress, this and that. Now, as you can see here, it can go down as low as possible. Okay, so that means no CPD. Now, gross CPD means I'm exactly opposite of this. Head cannot be pushed below the brim. And if you keep on insisting that, it will override and this thumb is lifted up. And obviously, there's no question of the fingers in the at the level of ischial spine feeling anything. So this is just overrides. Can you see here? It is coming above the symphysis waves. It is cross CPD. Now comes the borderline or the mild CPD, or some people call it moderate CPD. I would like to call it simply borderline CPD. Now here is the tricky situation. Head can be pushed in slightly into the brim. The conical part of the head goes slightly into the brim. But when it's going, it touches or kisses the thumb. It doesn't override the thumb. It doesn't go smoothly, but it just touches the thumb. And not only that, vertex is not felt by ischials at the ischial spine level. The fingers which are waiting at the ischial spine, they cannot palpate the vertex. This is the borderline CPD.